Ken, thank you so much for taking a few minutes today. It's been great getting to know you over the last couple of days and just hearing all the innovation, all the things you're doing, the trajectory of your career. Really, really exciting. So maybe we'll just start there. A little bit about yourself, your organization, your roles.
Sure. So my name is Ken Hogue, and I am the Chief Revenue Cycle Officer for United Health Services, which is located in the Finger Lakes of New York, so roughly within that 100-mile range. A little bit about me, I'm a prior military veteran, and also when you look within revenue cycle, I think my career path and story is a little bit as far as different than most. It was more like I was born into it, from military members working within healthcare and referring, but my grandfather as far as like primary care physician, and then working within the family's practice and business early on within life. I knew that there needed to be a change and innovation in order to drive healthcare forward, particularly to where the providers and the clinical folks could focus on working and seeing patients, which is what they love to do. And the administrative side of task, I knew needed someone to take on those challenges. And as hard as it may seem, or the labor of love as others will refer to it as, I enjoy the space of the healthcare administration and revenue cycle because the change is actually what motivates me.
Yeah, well, that's exciting. Speaking of change, I think change in healthcare, pretty much you can look those up in the dictionary. It's the same word these days. So given UHS's test site status, and I know that you're going to qualify that a bit, how are you using their emerging AI tools to transform your operations? And maybe if you share specific examples of what's possible now that maybe wasn't possible before.
Sure. So I think when we talk about AI and other things, it's really defining a charter for what the AI may be. And when you look within automation, it's really not new. It is in the capacity that it's being used. But when you go back to the 1950s or 1960s, when census reports were done or military enlisted statuses and, kind of the census related to those patient or to the population of those people, it needed to be tracked and done so within a automated type of way that could be repeated every year, so that way there were not variances within the data and consistent. So fast forward to where we are today, I think we've built upon those earlier parameters and have gone warp speed, but really that as far as initial foundation is not changed to what can we do, and can systems or technology do it more efficient than a human, but the human intervention still needs to be there as a subject expert or SME. So for UHS, when we talk about the testing and things that needed to be done, it's really understanding what we did well. And we went on to Epic in September of 2020 and using that automation, but also some of our other affiliates like our nursing homes and a few other things are not on Epic, but looking at it from a ecosystem for delivery of care for our community, and really needed to understand, again, what we did well, what we needed to improve on, and go back to communication, because without communication in business, I think that's where a lot of things go astray. And that's where we then redeveloped the culture. And the culture needed to change to technology, what is RPA, which is repeatable as far as tasks that a human does and what technology can do more efficient. But then when we go into true AI, it's either through Epic, some vendor partnerships or others. What is the learning mechanism of what is done in patterns to bring that to the forefront of our clinical providers and our financial staff, so that way when something is a variance or when something does not follow a normal pattern, that needs the eye and a very advanced skill set in order to understand that, not just the general norm of something that's a repeatable task. So when we talk about automation, I think that's really what we needed to do, and it's been around, but a lot of folks needed that reset on what is clinical AI, and really that is what we're testing. Working more with the Epic advancements of our EHR, working with our clinical and executive leaders. But to do that, it really was the culture change to where we needed to say, what does the organization need to do in order to help our patients in a concierge way. And that's where the culture has changed towards technology as a tool. Right. Communication is our actual robust engine. And the concierge service is how we make sure that our patients are cared for and know that we care for them.
Yeah, well, that's great. And I know, having talked to you yesterday, how passionate you are about that, because ultimately that's the end goal, right? It is the patient, and we forget about that so much with innovation and IT and interoperability, all these things where we're trying to connect and communicate. But at the end of the day, if we're not truly serving the patient, and to your point, communication is a critical component of that, then we're going to fall short. And with the competition in healthcare today, and you're laughing at that, but that, you look at all the consolidation, everything that's going on, it's absolutely critical. So, well, you're using an AI-driven payer report card strategy to better hold the payers accountable. And I know that's helped dramatically cut back on denials for you, but can you explain how that process works, how it shifted your payer engagement strategy, and why it's working, what you've done, because I know you've had a lot to do with that, and why it's working so well.
Sure, and happy to share. So I think, again, you're going to hear me refer to the stage as far as labor of love, because everything I think within revenue cycle has to be looked at from a resource standpoint, prioritization, but what is the end result, and to make sure that that end result moves, or that large rock item, because it's critical to the health system, it's critical to the community, but it's also our patients. Because again, when it goes back to the payer challenges, what we did is originally, before we went on to Epic, we had payer relations that was embedded under revenue cycle and joint ventured with legal, and that model is still in play today. But then when we talk about claims adjudication and all of that other thing, we know that it's a lot more data that needs to be synthesized, not on a monthly or quarterly basis. You really need to look within that data that's coming in week over week, and sometimes a particular day of the week, and say, what are those guardrails that you have for the scorecards and metrics? If it's initial denial rate, if it's the average days that I send out my claims for the organization and paid, or if it's requesting authorizations within revenue cycle, what is the average turnaround time frame? Because we know with the many challenges in the healthcare community, work resource efforts, payers are also strained just as it is from health systems, so it's about balancing that. So when we talked about AI, it was using Epic tools, particularly the payer platform, but also working with our claims adjudication system and coming up with something to where we can do that repeatedly, week over week, within a dashboard function, and drill down to where then it comes within a package that necessarily can be looked at weekly and monthly, versus a monthly package that was generated 10 to 15 business days after that financial accounting period closed. Because when you talk about the time of the change that you have to make, the change needs to be rapid response. And what I mean by that is, when data comes in every week, you need to know what is changed or what those issues are quickly. Because if not, the larger the health system, the larger the staff, and the larger the denial if you don't overcome. And denials delay cash for making us be able to advance in our organization and improve infrastructure and improve technology for care, but also to reinvest in our staff to make sure that, we're able to compensate them fairly, because it's really that rapid response, again, that it's a ripple effect if you don't balance that. So by doing that, we were able to shave basically 6 weeks off from having a full denial-related summary and an action plan, to where now we don't look at things as far as a monthly basis. We really look at them weekly and balance it to the monthly action work plan. That goes then to the quarter, basically work efforts and reports to my executive leadership and board. And then we've also made it a part of our strategic planning for the year of what revenue cycle needs to act as the catalyst to advance our healthcare technology and patient experience.
When you think of those waterfall timelines, it would seem obvious, right?
Yeah.
But it's so difficult to do, isn't it? It's
a mountain to climb, particularly Mount Everest, and you may be in a 1995 Jeep Grand Cherokee, with not the most advanced technology. But I think that's how do you armor up and adapt to change? And for me, with the organization, when we talked about AI, many leaders were apprehensive to the change, uncomfortable. But again, being a military child, my father, a 30-year military veteran, and myself, and moving, you had no, as far as resistance to say I couldn't adapt to change. It really created the person in who I am of having those crucial conversations, able to drive change and efficiency, but then make it more comfortable to people, knowing that it's not something other people are comfortable. But that's where, again, the communication skills and technology, it's starting, as you said, with sites or beta test like locations to get people to be able to digest that, so you're not feeling like they're forced, but they need to then become a part of that decision to create that ecosystem to drive the change.
Yeah. Well, I know that you've embedded a tech assistant patient concierge service throughout the revenue cycle. So I know that makes it easy to expedite referrals, appointments, care delivery. Maybe if you could just give us a little bit of insight on how that model works, the kind of impact that it's had, and it's constantly innovating, right? So where do you go next?
Sure. So for me, it really started with New York State made the changes to where we were no longer able to credit report before other states across the country was able to do so. We really have had this implemented about over a year for our organization, as it was the fall of 2022 when we were notified your change had to really occur within 2023. Credit reporting was a tool that was used to drive patient collections, and many thought that that was a traditional model that helped organizations to be able to be sustained and also sustainable financially. But I think that when we talk about the patient experience, it really was a negative. So how do you then back up from a traditional model that's been in place since the 70s and really be like, how can we engage with our patients? Hospitals provide top quality services, and really if they're advancing within the care, then to do that, patients want to pay. It may be there's obstacles in they don't know what resources. They may have lost their job or had a hardship for 6 months. And instead of just saying, if you don't pay this minimum amount, we're going to send you to collections, that's really where I have worked with my team and organization to be innovative, to where we call it self-pay and patient forensics. And we came up with that acronym to be catchy, because when you say forensics, it's like, is there a crime scene? Is there something that needs to be digested? Some CSI in there. But then we needed to come up with a phrase that really was bold in order to let our organization know, like when we're talking about patient and self-pay forensics, it's understanding their environments, it's understanding their home life, their financial situation, and understanding their social deterrents and barriers to care. So we started on the back and worked forward. Organizations really looked within referral patterns to create access of care, but sometimes with the pandemic, health systems were challenged with resources and providers to get people scheduled, because it unbalanced our entire healthcare delivery within the United States and worldwide. So to do that, we knew that we needed to reset the front, and we did that with Epic, with referral modules and a concierge part of intake to our specialty services, and embedding those referral specialists within the practices, and also an escalation that goes to a centralized model. But then when we knew that self-pay regulations were changing, that's when we knew that patients felt the white glove approach to, and at least at our organization, we refer to UHS as our house. Our employees are very dedicated to the organization and community that they live, work, and serve. So when you take a hotel type of approach, it's really able to say, how do we make this a part of the revenue cycle experience, from when they need to check in or have a reservation or referred to us to stay in our house? And that's kind of the approach that we took. But then when it comes to the revenue cycle or the patient balance experience, it also is from A to Z, what is the start and the finish, and how many touch points has a patient had to have in order to provide that service? And was that a referenceable experience to where a patient is able to say, I had great service and they helped and explained it to me and it wasn't overwhelming, and helped me be able to break down barriers. Because when you talk about revenue cycle, organizations in healthcare, it's so complex. Everybody who works in a healthcare setting and has families, they're always like, can you help me with this? I don't know. And we become our own patient financial counselor for our entire families. But then I really took that and worked with my team to do, again, more of a pilot. We started with, collection agency, prior manager, and hired her to be a part of our organization and built the self-pay concierge team on the back end. And that allowed us to be able to look at these social deterrences and barriers to work with our patients, not just have a 5 or 10 minute phone call, you owe this and need to set up a payment plan. It's understanding the forensics and having a crucial conversation in a respectful way to our patients so we can help navigate them through patient financing options long-term that may need to help them. Is it veterans relations and working and partnering with them for the VA for benefits that they should be entitled to? Is it 9/11 patients that family may have been impacted because they served during that time, or state funds? And that's where we're like, instead of telling the patient, you need to make the phone call and do this, we want a single point of entry, even if it's on the backside, to say, here's what you've presented us with, and we are the concierge service for the organization on the back end to take all of their concerns and escalate them to the appropriate department, or get the referral and do that for them. So if it's referring to community services, helping them apply for Medicaid or state regulation as far as grants, that's really what the concierge service model turned into. So not only from the referral to our organization in our house, but once you're in our house, we want to be that reputable brand in order to basically be able to say to our patients, we know this is hard. We know that there is a lot of information you may not understand, but we're here to help guide you through that and answer your questions because we know it's overwhelming. And basically that white glove approach through some of those things that patients and other organizations may say, well, the patient was not compliant, but why? Is that because transportation issues? Is it because they have some other financial concerns that maybe they're too proud to discuss within a traditional office or hospital setting? So you need to have that in a more respectful environment to where a patient feels comfortable to share those instances.
Are you doing that? So I love that you say that in-house.
Yep.
So you're not outsourcing any third party to do that white glove service. That's
It is completely taken.
Was that your design?
It was, and it was a pilot. And really what I thought about is, we still have the vendor partnership with bad debt collections, but we don't credit report.
Right.
And they will work some of that overflow for patients that are not compliant, but they still have that white glove approach and saying that, it's gone through here, but can refer back to our team. But our team is really that person to do that. And we took 6 of the most experienced staff within revenue cycle and created a higher position. And to do that, we were able to then say the people working our self-pay accounts have about 20 years experience on average. So they're expected to know the insurance regulations. They may have worked in customer service or billing and denials before, so they understand what's denying and maybe what asks from a patient, instead of, I understand, I'm going to put an investigation in and send this back to billing when it's really something the patient needs to fill out. So by doing that, we were able to have the skill set that was needed to work through that. But the concierge team of listening, empathizing with the patients, and really working on tactics of talking softer and sometimes not talking at all to let that patient de-escalate, because that's the first time that they've been heard.
Yeah.
Instead of just referred, through the system and, stated like, this is all of my department, now you need to go to another department. We wanted to minimize the touches that a patient had to do. So they were like, we know the organization has our best interest and we can speak to this team and they can help us with any part of the process in the organization.
Yeah, those friction points are so frustrating for patients.
Yes.
Because there's so many, it's exhausting. And yeah, that's really remarkable that you're doing that.
And touch points have to continue to evolve. I would say, like, we're probably building that team out further because, again, it was a pilot that's grown. And I think for our organization, it's going to be one of those innovative things that we are very proud of. But then, too, it's as the business changes, that model has to continue to evolve and change and have innovative suggestions and ideas from what was my initial hope and dream of building out. Because I saw, particularly my grandfather, go through an experience at another health system, and there were 13 touch points between the family to get an issue resolved. And I'm like, this is nauseating for us as a family, and I'm a healthcare executive. I need to look at this as if all of our patients were one of my family members, how can I help them be able to digest this and do so in a more respectful way? So with that, the concierge team has taken average number of a touch to bring an account to zero with self-pay balance from the whole journey of about 13 touches to under 7 or 8 within the average within about an 18-month period.
That's great. That's really great. Look, just moving on here, AI's just sticking in the frame of AI, obviously within healthcare, is so vast, as evidenced by all the initiatives, obviously you've discussed. But in getting there, what roadblocks? I'm sure we could probably just do a whole nother session on that. But what roadblocks have you encountered, and what are you doing right now to overcome them?
So really, I think it's about governance. So when I talk about governance and prioritization, it's tools that can be used within any business model, if it's clinical, financial, or even outside of the healthcare industry, right? Like, or if you do HR within healthcare. Understanding those, defining that charter, and making sure that those are communicated, and then also posting to make sure that those barriers have not changed or morphed into, here's the next issue that we're going to be addressed with, and staying up with them. So in order to really overcome those hurdles or barriers, it was about building relationships. Previously, I think, change for some organizations, including ours, was very hard, but it was having those respectful communications to be like, this is what I'm seeing with that pilot, sharing that success story, having some of our patients share their success story with the organization and community. But then also it was doing an inventory for about a month long and getting my team and myself out within our practices and hearing what they were struggling with. Because when you have resource challenges or turnover within the front desk or the front offices, you always are thought of like, how do we get this information as efficiently and as fast as possible? So that's where then I needed to tailor the intake of what we needed to do from people, RPA and IA automation, in order to see what is the recipe that I need to come up with for the revenue cycle and then post point. So it's once we have implemented, it's the charter, it's getting the buy-in from our clinical leaders, our executive leaders, our communications team, and sitting around the table and having a conversation on a monthly basis of what revenue cycle would like to recommend, and not just one option. We need to come with, here's option 1 or 2, or preferably 3 options. So that way the leadership team and others say, I've had an input in this decision. It's not a forced change. And we know that, I always tell my team, we need to be innovative. It's a part of who we are, but also to drive for success, because healthcare is very challenging. But if we are doing our job correctly, there is always room for improvement. But it's how we prioritize those into those big rock items to be successful. The small automations and processes may work, but as we're seeing the work streams, we need to go after those bigger items. And it could be, here's 200 ideas that practices and physicians and others have had. How do we then roll those within 5 or 10 categories to say, here's the big boulder, or here's Mount St. Helens that we need to climb, right? And as far as not erupt and keep balance, to where then we have some homework to do, and then that's where we work within subcommittees. So again, it's prioritization and really a charter for as far as what the problems are, and then it's really going to work with technology, people, and your insurance payers to have the conversation of, it is a collaborative effort on all fronts.
Yeah. Well, and you had talked about problems and guardrails, those go hand in glove, right? So, what proactive steps are you taking to guard against those anomalies and biases and, technical limitations that are, they're going to hurt the outcomes and the efficacy of the tools you're using, right?
So really what I'm working with on my team today, and then I think our whole organization is working on, is servant leadership, because we don't know everything. And honestly, we are the experts we are only because of how well we are read or how we have learned and adapted to change. So really working with the team and getting their input and ideas, because those that work it every single day are the forefront. They may see something small, but then how can we then take that and turn it into something big? So it's really of when something's implemented, pulsing, but when we look within healthcare regulations that are changing, it's beefing up compliance to be embedded under revenue cycles, so that way we can know of the changes that are talked about and proposed, to make ideas and to make work streams of here's what we're going to draft if this is implemented, and go from a reactive, we have 90 days to put this in, which many regulations are within, 3 to 4 months, but it's also planning. And it's like, what are we hearing in the market? What are we also seeing at the national level? What are we seeing at the regional level? And then what is happening within our community? And is it, food disparities, social determinants of transportation to come to our healthcare facility? So it's really looking from the outside in and bringing that involved within revenue cycles. So that way we can say, this is what's proposed. How can revenue cycle help? How can we partner with clinical? And then literally our compliance team under revenue cycle coordination reaches out and gives a summary and says, this is what we're seeing and this is proposed. This is now within the state and federal statute for change. And then once that happens, we're like, we need to have an action plan with the definitive action items, because it most likely will be coming to fruition. So we have no choice but to plan and execute a delivery for if it is implemented or signed off on.
Right. And I love the qualification of all of that falling under the purview of servant leadership, because we learn. We don't have all the answers, right? When you're the top of the food chain in your organization when it comes to revenue, right? And that encompasses a lot, and yet you're constantly learning from peers. So maybe a good question then would be, what insights or lessons learned should your peers keep in mind as they begin to explore some of these innovations in AI? Because it's a lot, it's a broad category, and like we said, it's vast, and we still don't, it's the great unknown right now. So, what counsel would you give there?
To me, what I would give to my peers and just others, don't be scared to put your foot in the water. You're not going to put your toe and tread and say the water's cold. You just have to plunge, and then be like, once you plunge in, it's like, let me dissect what all I am faced with, and the barriers and challenges and concerns, and also the resistance, and also those that's uncharted. Because when you're in uncharted water, you need to analyze what you can recall on and what you can't, and then that you don't, that's where then you need to explore and you need to educate yourself. So to me, I give myself a grade every single day because I'm very much a numbers and metric person. I will grade myself on a daily basis and give myself a grade from either an F from how I perform that day to an A. And there are many times when I'm seeing it's like, okay, I have 20 things on my list. I didn't get anything off, and there's additional barriers. That's when I'm like, am I focusing on too much of the smaller things instead of the senior strategy levels that I need to as the Chief Revenue Cycle Officer? And if that's the case, then I also need to see who on my team can help, because we're all in this together, see and give them some direction of what I'm looking for. But then if I don't have that within my inventory or staffing, then that's also where I need to advocate for. We may need to make changes. Someone may need to be certified in another area. So that way it's the collaboration of we have the tools and the team effort. But really when I do that, it asks people to reflect on yourself. When as the senior leader of the organization, are you bringing things to closure on a weekly and monthly basis? Because if something continues to circle, that's where I may have given myself a D the week before, and I'm like, this is still on my list, but are we making progress? And am I getting the meetings that I need to buy in for the change? And if I am, then I'm like, okay, we've taken a D, we got regraded, we're a C+ on this item, but it's still not to the level that I want it to be. And that is where I meet with my boss and executive leadership, and I'm like, this is what I'm seeing in the barriers. I need help to work and escalate these because it's outside of revenue cycle, but this is what I've done today, and I want your help within the culture or organization. Or do you think that it just takes more time and more as far as like penetration within communication in order to get that out to the departments, because it's such a large change that they may need more succinct communication to give them tidbits in order to digest what really is being asked of them. And by doing that, I would say in the last 2 years, I am so proud of my team and the organization for really like where we have moved, and what I thought was impossible is now beyond impossible. And the recognitions and accolades that I have received in our organization, it just was me trying to make a change and innovate for what I thought was right. And then now going off of that and building and saying, we did this, what else can I do and be faced with? But it's the communication, but more so that grading. Because if something continues to circle, I would say to my peers, have a crucial conversation in a respectful way, but come with your information as if you are a prosecuting or defense attorney, and you need to be prepared. Because if you don't put the labor of love into researching what you're trying to adapt to change, people are going to see that you are not personally committed and involved, and then they are not going to be if you are not.
Yeah, for sure. And with the rapid pace of change, and we look at AI and technology doubling its domain knowledge base every 24 hours, you can't procrastinate. Because the bottleneck just gets worse and worse. I love the grading. I love the self-accountability. There takes a humility in doing that, because it's one thing to grade yourself.
Yeah.
And then it's also another thing to what's the action item? What's the next step, right? So with that in mind, what's the next step for UHF? You know, when you look to innovate, what is on the horizon, and why are you prioritizing that specifically?
So for me, I think it's continued to leverage in the organization to realize revenue cycle is a catalyst to advance the organization, but also for our patients and community to understand the challenges. We need to let them know that there are legislation changes that's impacting their patient out-of-pocket or their patient experience. It's not just the health system making the decision to where a patient's confused. So how do we better proactively handle that? How do we advocate for change and innovate at both the local, state, and federal level? Because patients that also have social deterrents of health are delayed care or not seeking care. And that's something very near and dear to my heart and my teams, to where, again, we can use revenue cycle data if it's adjustments or denials and challenges, and say, this is what we're seeing with our patients. But then how do we also go after that with insurance carriers and also state and federal legislation? Because when we talk about mental health, when we talk about as far as oncology related care and others, those services are growing so rapidly because it's needed. And many people put things on pause with COVID. So now they're coming in and we're catching up still of where people put conditions off, and now they're more serious. So then it's more advanced in what needs to be done, but it's also letting that person know it's okay, whatever part you are within your journey, we're here to help. Transformation is something that I think always has to be done with every new upgrade of Epic for our EHR, regulation changes. That's where we need to understand what those truly are and what we can do, and then make sure that we advocate for change if it's not in the patient's best interest or if it's not within the health system's best interest, because many people may not know health systems' profit margins are razor thin. People think people in hospitals make so much money, but when you have to reinvest within uncompensated care, a community, and if you're a nonprofit health system, it's your duty to give back to an organization. So if we're not able to do that, and as far as be profitable, then we're not able to reinvest within our communities and our people.
Yeah, well listen, Ken, you'd make your grandfather proud. Thank you so much for the wealth of knowledge. Thank you for your time. We genuinely appreciate you.
Thank you. It's been an absolute honor to be here this week and a part of the conversation. I really appreciate it.